So, good morning, good evening, good afternoon to all of you who have decided to participate in the International Society of Sexual Medicine WPATH webinar on transgender adolescents' health, the role of puberty suppression. So it's a pleasure as the president of the ISSM to invite you and see you all for this webinar. Can I have the next slide? For those of you who do not know much about the ISSM, because I hope there's a lot of WPATH members here that might not have, maybe you haven't heard about the ISSM. The International Society for Sexual Medicine has a mission that every human being has a right to a healthy and satisfying sexual life. And we also have a vision that we would like to be the most respected and trusted source of information, education, and professional development on human sexual health through the delivery of world-class publications, research findings, online and in-person opportunities for knowledge exchange worldwide. And that's why it's such a pleasure to have this webinar in collaboration with you, WPATH, where we can really both fulfill our mission and our vision, and hope that we will have a very fruitful discussion and a lot of good presentations. The next slide. If you are a member of the ISSM, you have some benefits, and some of them are that you have the access to our journals, which are the Journal of Sexual Medicine, our Sexual Medicine Open Access, our Sexual Medicine Reviews, and our video journals. And we also have a web page. We have a university where we have a lot of recorded presentations on sexual medicine. So if you are not a member, you might consider to become a member. But first of all, I would like to say thank you to WPATH for making this webinar possible together with us. We have an excellent faculty, and it's a pleasure to welcome also our moderator. And last but not least, give the word to the president of the WPATH, Walter. Please take over, and it's such a pleasure to be here with you today.
Thank you, Annamaria, and like you, I am very pleased about this joint venture between ISSM and WPATH, the World Professional Association for Transgender Health. And for all of you who are unfamiliar with WPATH, we are a global association for clinicians and other professionals working in transgender health in its broader sense. Our mission is to promote evidence-based care, education, research, public policy, and respect in transgender health. And we envisage a world wherein people of all gender identities and gender expression have access to evidence-based healthcare, public policy, and justice and equality. So one of the very important parts of WPATH is the standards of care. And can I have the next slide, please? The standards of care is the clinical guidelines of WPATH based on the latest scientific evidence and clinical consensus. And currently we have the 7th version of the standards of care, which was published a decade ago in 2011. But in 2018, we started work on the SOC 8, on the next version of the standards of care, which is expected to be completed by the end of this year. And more than 100 clinicians and academics in the field of transgender healthcare and community representatives have been working very hard together with Johns Hopkins University under the leadership of Dr. Eli Coleman, who is the current SOC 8 chair, and Drs. Asa Radix and Dr. John Asellus, who are the co-chairs. Once published, it will be universally available for everyone. So next slide, please. So I've already mentioned Dr. Eli Coleman, and he is here with us as moderator of this webinar, and it gives me great pleasure to introduce him to you. He really is a titan in the world of sexual medicine, sexology, and transgender health. Former president of WPATH, of WAS, of SSSS, and of the International Academy of Sex Research, just to name a few. He is also founding editor of the International Journal of Transgender Health, formerly the International Journal of Transgenderism, and he's the current editor and as well founding editor of the International Journal of Sexual Health, holding the first endowed chair in sexual health at the University of Minnesota Medical School since 2007. So he's a great friend and a great advocate for everything to do with sexuality. So Eli, very warm welcome, and the floor is yours.
Well, thank you, Walter, and thank you, Annamaria, for inviting me to moderate this, which I think is an extremely important and timely session. And we have three outstanding speakers that you are going to be able to listen to today. And I want to move on as quickly as possible to give them as much time, because this is a very important topic. We're in the middle of a culture war around the world, and the front line is transgender care for youth. And the battle lines are drawn. We are in court fighting this. Gary Butler today is in court in the UK fighting for transgender rights, particularly for youth. And so we are going to present some of the most important issues that everyone should really consider. And excited to introduce our speakers. They will speak for 15 minutes. Please, in the chat, you can say hello to everyone. We have people from all over the world, from Bangladesh to Vietnam to Europe and USA and Australia, New Zealand, everywhere. So welcome all of you. So you can use the chat function to greet people, but for your questions and answers, use the Q&A button and mention the name of the speaker to whom you're addressing the question. We plan to have a lively Q&A session after these three speakers. So let's get started, and let me introduce my dear friend and colleague, Annelou de Vries. Annelou is a child and adolescent psychiatrist working in the Amsterdam Center of Expertise in Gender Dysphoria. Since the early 2000s, an important special part of her work is dedicated to transgender adolescents. Annelou has authored various publications, key publications, the publications that we rely on so much in terms of puberty suppression, and is currently leading several studies on mental health and treatment evaluation. Internationally, I am working directly with her in the Standards of Care Revision, SOC 8, which Walter mentioned. She's chairing the Adolescents chapter, and she's a board member of the European Professional Association for Transgender Health. Annelou, thank you for participating. Welcome. We look forward to your words.
Hello. So thank you for the introduction. Thank you for the invitation, and everyone, thanking for your participation. Yes, I've been around for a while already in transgender care for adolescents, but I think we should realize that still it's a relatively young field of care. It was only in the 5th edition of the Standards of Care that there was a chapter on children and adolescents. And first, the Amsterdam clinic opened around that time. And I think there were just very little places around the world where specific specialized transgender care for adolescents or young people was offered. And it's around 2 decades now that we have a specific protocol, the Dutch Approach Protocol, it's also called, that includes puberty suppression. So next slide, please. So one of the things I think everyone puzzles is that of prevalence. What you see here is the Amsterdam cohort of gender dysphoria study. In 1993, based on all referrals to our clinic, the Amsterdam clinic, which sees actually the majority of transgender individuals in the country, in the Dutch country, based on their referrals and treated person, estimated the prevalence rate, and it was thought to be a rare occurrence, transgenderism, what it was called at that time. That same design was replicated a couple of years ago, and then you see quite different numbers already. So a 20-fold increase in prevalence based on treated persons. And interestingly, these are the trans men. You see that especially that group of referrals has increased. And the young population. So that is the children and the adolescents, the dark and the light gray bars here. And what you also see is that within the adult population, the 18 plus, the mean age dropped. So of the adult population, it are especially the young ones that come in recent years. So overall, we see many more younger transgender individuals in the clinics. But when you ask it in the population, and it's only now that populations-based studies occur, here's a recent one in high school waves, 2.7% of the individuals there identify as transgender, genderqueer, gender fluid, or unsure. So yes, gender diversity seems to occur at not rare rates, but it's pretty prevalent among young people. Next slide, please. And we see that also in the clinics, not only in the Netherlands. So these are, the blue bars are treated individuals, and the orange bar are referred individuals, young people. And one of the problems is that it gives, at least in our country, and I know other countries face that also, long waiting lists for specialized care. This is a study from the Nordic countries, the same increase in referrals, and England also. So next slide, please. And what's also changed over the year, not the prevalence or the number of referrals, but also the conceptualization of gender. Increasingly, we realize that gender is not one thing. It's not just gender identity. It's also gender expression. It's the biological sex, and it's your sexual attraction or your romantically attraction. And it are all different facets of the gender spectrum, where we also realize it's not either male or female, but you can have male and female characteristics on all these aspects of gender. So next slide, please. And that gives us thought about typical versus gender diverse development. When you think about children, when they grow up, for the majority, it will be the case that gender role, gender identity, and biological or assigned sex at birth match. Whereas for the gender diverse or gender non-conforming development, it is the case that gender role, gender identity, and birth assigned sex do not match or are incongruent with each other. Next slide, please. And when you think about children, of course, you think about identity and you think about crucial moments in development. And usually, toddlerhood has been seen and viewed as one of those crucial moments in development, gender identity development, where cognitive and social development are at stake, and children start to realize if their birth assigned sex is either male or female, While realizing that at a cognitive level, they usually also start to identify themselves as belonging to that specific gender. But of course, when young children grow up, things may fluctuate. Around puberty, of course, another important phase in life, is it true that gender identity is fixed at that moment? Well, for some it's not. We know historically already that in adulthood, there are transgender individuals that only at that age realize their transgender experience. What we should realize in children is that most studies are on normative gender incongruent or gender identity development, and more so on gender development and not so much on gender identity, whereas the studies on gender non-conforming gender identity development come from clinical samples. So we should also realize that with regard to gender identity development, we know a lot, but there's also a lot we don't know yet. And we have to face those uncertainties while working with transgender youth. Next slide, please. And that makes that when working with children clinically, we make a distinction between when we see children, whether they are pre-pubertal, whether they are in adolescence, or whether they are adults. Next slide, please. So in our Dutch clinic with that long tradition of care, can I see the next slide? For pre-pubertal children, we have the approach that is named by others as the watchful waiting approach, where we see the children, we carefully evaluate them and look at their resiliences and vulnerabilities, because some of those children may be, due to their gender incongruence, may be shy, anxious, or have difficulty within their families, and we support them with that. But with regard to development, we try to keep all possibilities open and support the child and the family in a period of what is called waiting, where we label the behaviors and the expressions carefully and leave a social transition, preferably till late childhood. Although when people and families prefer to socially transition early, it's good to weigh the pros and cons of such a step. But no medical intervention in pre-pubertal children. Whereas for adolescents, and that's the next slide, please, the uniqueness has come that puberty suppression as a medical intervention can be offered at quite a young age already. With the goal to create time and rest for further exploration before any decisions about more irreversible steps are made, to stop further physical puberty development and optimize psychological health during puberty and adolescent years. For long, the criteria used to be that there should be childhood gender nonconformity, some experience of puberty, no interfering psychosocial difficulties that make it difficult to carefully assess the adolescent. It should only be given in a supportive family or other social network, while the child or the adolescent and the family has a good understanding of what treatment includes. And the puberty experience should be at least to 10 or 2. Next slide, please. And that means that it looked like this. First, children or adolescents come in the clinic. They are evaluated, no medical interventions yet, followed by the start of DNRH analogs or puberty suppression, a fully reversible treatment. And then around the age of 15, 16, you can start with hormonal treatment, partially reversible, and only after age 18, surgeries. although mastectomies can be offered at age 16. So this was the model, how it was developed. Next slide, please. And one of the key studies that showed indeed effectiveness of this protocol was a study where around puberty, so before any puberty suppression was offered, the adolescents were seen and their general functioning, their emotional and behavior problems, and their level of gender dysphoria was measured when they were about to start with growth hormones or affirming hormones, and after their affirming surgeries again. And what you see is that their general functioning was steadily increasing and improving, while their emotional and behavioral problems decreased, and their gender dysphoria was resolved completely, but only after the hormones and surgeries, not on puberty suppression only. So these were promising results, especially if you think that these scores were fully comparable with same age peers around the age of 20. Next slide, please. And for long, I think not so many studies were published that confirmed this model, but recently, especially the last year, I should say, other follow-up studies have been published that all direct in the same, that all point in the same direction, with improvement in psychological function and improvement of gender dysphoria. Although numbers are often small, and also the study samples are including a mix of adolescents that use puberty suppression or puberty suppression combined with hormones. And the follow-up is not so long. So usually 6, 12, maybe 36 months, but then it was only a small group. So such a long period, as I showed in that earlier study where we had a follow-up of almost 7 years. That's not replicated yet. Next study, please. Or next slide, please. With regard to outcomes in physical health, I think Gary Butler will show that, but of course people have been worrying about what are the influences of puberty suppression on physical health, cardiovascular health, body mass, bone mass, but also brain development. Next slide, please. That brings me to one last point. So one of the things that's become really important, that when children start early, of course, they also have to make decisions around fertility at a young age and fertility preservation at quite a young age. And that's an issue we deserve a lot of attention to at present. Next slide, please. That brings me to the conclusions that, yes, over time, I think there have been changes in our conceptual thinking about gender. It's not a binary, but it's a spectrum. And when we think about gender identity development, we distinct between childhood, adolescence, and adulthood. There are, yes, increased rates of requests for medical affirming treatment in young people. And so far, we see positive results of that. But they have lifelong effects, and especially regarding fertility, which leaves us careful with this medical affirming treatment in the young ones. Thank you.
Thank you so much, Annelou. Great presentation to start us off, giving us a very nice overview. We have some really good questions in the Q&A we'll get to. But I just also want to thank you for your dedication to this field, for doing the important science that advances our field and provides more access to care for youth. Thank you very much. I'd like to introduce our next speaker now. Rita Katiala is a professor of adolescent psychiatry in Tampere University in Finland. and is the chief psychiatrist in the Department of Adolescent Psychiatry there at the hospital. And since 2011, this has been a major share of her work on gender identity development in adolescents and child assessment and treatment of youth with gender incongruence. She is the leader of one of the 2 gender identity services for children and adolescents in Finland, and has participated as an expert member in a number of national health policy initiatives related to transgender health, as well as in numerous national and international education activities in the field. So please welcome Rita. Thank you so much.
Thank you, Mr. Chairperson. Hello, everybody. It's a bit exciting because we're meeting virtually. I don't see any of you, only the co-speakers in small pictures. But nice to meet you all virtually. I'm going to talk about mental health of transgender adolescents and what is known about that and what is not known. Can I have the first slide, please? Firstly, I want to quickly introduce to you what kind of research has been published, because the quality of the research is, of course, the basis of the knowledge. So there are, to my mind, there are four different kinds of studies that advise about this question. There are studies reporting prevalence of mental disorders and psychiatric symptoms, as well as correlates of these disorders and symptoms among gender-referred adolescents. This is those who have been referred to specialized gender identity services and seeking gender reassignment. Then there are studies describing self-reported emotional and behavioral disorders and symptoms and their correlates among transgender identifying young people in LGBT surveys. With this, I mean surveys that have been carried out among LGBT communities, and as one of the groups included is transgender adolescents. Sometimes they have not been separated in reporting the results, and sometimes they have. Then there are studies reporting emotional and behavioral symptoms and their correlates among unselected adolescent populations, such as school populations, college populations, and this kind of samples that represent almost unselected sample of adolescents in the country being surveyed. And recently, in increasing number of surveys, there have been questions that in one or another way identify those who identify transgender, and it has allowed making comparisons between transgender and identifying and cisgender identifying adolescents' mental health and its correlates. And then there are follow-up studies reporting changes in mental disorders and psychiatric symptoms within groups who proceed in gender-affirming treatment. Can I have the next slide, please? All these kind of research has unfortunately a lot of limitations for the time being. Cross-sectional studies cannot provide information of causal relationships. If you can find in cross-sectional studies that A is related to B, then you don't know if A is influencing B or B is influencing A, or if a third factor is influencing both of these phenomena. Then there is selection bias, which results in low generalizability of findings, particularly in studies that have been carried out solely in communities of LGBT young people. The problem is that you don't know if you get findings of mental health symptoms and their correlates, whether they are similar or different from that in mainstream adolescent population. If you use studies that have retrospective accounts of past life events such as trauma background and other negative experiences, then there is the problem that retrospective accounts are always vulnerable to memory biases. A human being has an inherent desire to make his or her life an understandable narrative. And therefore, if you are feeling bad at the moment, you're more likely to remember negative events. And if you're feeling good and happy, you're more likely to remember happy events and forget the negative events or perceive their impact on your life as waking less than when you are in a negative state of mind. Therefore, there is a risk of bias in retrospective account of past life events. And the few available follow-up studies, as Annelou already mentioned, are small, and they have used a large variety but a narrow scope of measures and mainly cover only short follow-up periods. Next, please. Nevertheless, we can conclude that we know now something about mental health among gender-referred adolescents. Descriptive studies of adolescents referred to specialized gender identity services at different countries, particularly or mainly in Europe and North America, have mainly suggested that approximately 40 to 45% of these adolescents present with clinically significant psychopathology. There has been quite a variation between different countries from 1/3 to 3/4, but mainly they fall within this range of 40 to 45% with clinically significant psychopathology. The most commonly reported disorders in this population are depression and anxiety disorders. Self-harm and suicidal ideation or suicidal behavior are also common, whereas conduct disorder and antisocial development appear not central in this population. And an increased prevalence of autism spectrum disorders varying from approximately 6 to 20% has been reported among samples of adolescents referred to gender identity services. Next, please. And this prevalence of autism spectrum disorders vastly increases the prevalence of autism in the population at large, which is about 1%. Are then the reasons for increased psychiatric symptoms or prevalence of disorders known? Stress that relates to secondary sex characteristics, heteronormative discrimination, and or negative parental reactions may predispose transgender adolescents to psychiatric disorders. And this would be specific to the situation of transgender identifying adolescents. However, adolescents with gender dysphoria may also develop mental disorders for unrelated reasons that likely resemble etiologies common in the developmental phase at large. For example, severe somatic illness or traumatic events that are independent of the person and the person's behavior, or problems in peer relationships or intimate relationships that may not relate to person's gender identity, are typical etiologies of mental health complaints among adolescents at large, and they of course also occur within transgender identifying adolescents. Also, the genetic predisposition to some severe mental disorders likely distributes in the same way in adolescents with gender dysphoria than among adolescents at large. Disorders may also precede the onset of gender dysphoria, and also they may precede the onset of puberty, which might imply that it is not the secondary sex characteristics development in puberty that predisposes to these disorders in all the cases. Autism, of course, is a developmental condition not secondary to psychosocial or psychological events. Next, please. Autism has been found more common among children and adolescents with gender dysphoria than in the child and adolescent population at large, and it creates challenges to assessment and treatment of gender dysphoria in minors. On the other hand, gender variance has been found more common among children and adolescents on autism spectrum than among same-aged peers at large. However, it is not known how the association between autism spectrum and gender variance or gender dysphoria develops. Several theories have been presented, and some of them might explain the development of gender dysphoria among young people with the assigned male at birth, but not among those assigned female at birth, and some might better explain development of gender dysphoria among autism spectrum children assigned female at birth and not so well maybe fit to males at birth. But at large, or in conclusion, it is really not known how these associations develop. More research is needed into the associations between autism and gender dysphoria. Next, please. Then we have a look at transgender identifying adolescents in the population. Community level information suggests that transgender identifying youth present more commonly than their cisgender peers with depression, anxiety, and self-harm or suicidal behavior, as is the case among gender-referred adolescents. Some studies have also suggested an overrepresentation of eating pathology in this population. Further, occasional population studies that have started to emerge recently have also suggested an overrepresentation of substance use behaviors and unhealthy eating and smoking behaviors among transgender identifying adolescents, as well as other risk-taking behaviors, such as sexual risk-taking behaviors. However, antisocial behaviors and aggression problems do not appear a central issue in this population, based either on gender-referred samples or population samples. Correlates of internalizing symptoms and disorders have been reported: lack of parental support, lack of peer support, and peer victimization in this population of transgender identifying adolescents. It is of course important to reflect that it is typical also for the age group at large that parental problems or problems with relationships with parents and peer victimization, isolation from peers, and lack of peer support are typical correlates of mental disorders in this developmental phase. Parental support is correlated with less experiences of peer victimization among transgender identifying adolescents, as well as among their cisgender peers. It is of utmost importance to keep in mind that adolescents are in the developmental phase where the parental support and parental guidance is very important for the development, and parental support is really influential also on the field of peer relationships and how adolescents what kind of resilience they develop in peer relationships and how they navigate when they face difficulties in peer relationships. Safe and supportive school climate also appears to diminish the strength of negative correlates, so that in case the negative events occur in the life of the adolescents who identifies transgender, then if there is a safe and supportive school climate, then this diminishes the impact of negative correlates. Next, please. An important question is whether gender-affirming interventions reduce psychiatric symptoms and improve functioning. And Annelou already mentioned this Dutch protocol, so I don't go through it again. But I also took the starting point, her studies of first groups who were treated with puberty suppression and later gender-affirming hormones and later surgeries. And of course, notice that those participants in this early and so far longest study improved as to gender dysphoria, body image, internalizing and externalizing symptoms, and were well adjusted in late adolescence and early adulthood. Although this group was carefully selected, as Annelou already said, that there were selection criteria who could enter this intervention, and they were doing quite well to start with. And as a group, they did not show severe psychiatric symptoms in the baseline either. Next, please. Can I have the next slide? Later reports have unfortunately been very short-term studies. Short-term follow-up studies suggest that gender dysphoria reduces, particularly with gender-affirming interventions, and there are few regrets and a great satisfaction with care. Several studies have reported reductions of psychological distress and psychiatric symptoms among adolescents from before the puberty suppression intervention to after it, and particularly to after gender-affirming hormonal treatments. But often within a non-clinical symptom range, which means that the symptoms were not clinically significant to start with. And other studies have not shown reductions in psychiatric symptoms or have not been able to demonstrate that changes in emotional symptoms are due to the hormonal interventions. It has particularly not been shown that severe psychiatric disorders would resolve with hormonal interventions. It is of utmost importance to keep in mind that adolescents who present with gender dysphoria and severe psychiatric disorders also require all the state-of-art psychiatric treatments that are usually used with these interventions that are usually used with these disorders, because we cannot expect that the disorders resolve by themselves with the treatment of gender dysphoria. Particularly in the early years of our activities in the gender identity service in Finland, we often saw the situation that other needs that the adolescents presented with, such as educational needs, child welfare needs, or need for psychiatric treatment were ignored because everybody expected that all the problems would resolve with the resolving of gender dysphoria. Research has not been able to demonstrate that this would be the case, and all the other needs have to be met appropriately, while in the same time considering gender dysphoria and the interventions that might require. Next, please. Important question is whether puberty suppression or does then puberty suppression create a risk to age-appropriate neurodevelopment? The upsurge of sex steroids in puberty bring along not only the development of primary and secondary sex characteristics, but remarkable developments in brain. For example, synaptic pruning, myelinization, gray matter maturation, functional connectivity, maturation of the prefrontal cortex. These happenings in the brain tissue are important prerequisites for a vast number of neurocognitive developments, such as more effective abstraction, perspective taking, integrative thinking, social cognition, and competence towards adulthood. And these again are prerequisites of development of mental health and functioning personality. Next, please. And this is the last slide. It is not known currently whether the influence of steroid hormones in the early stages of puberty is enough to initiate all these neurocognitive developments, all these structural and functional changes in the brain that produce all these vast and important neurocognitive changes and cognitive maturation towards adulthood. Is it enough that the steroid hormones give the impulse early in the beginning, or is it then needed that steroid hormones should have a longer action? It is possible that there is a window of opportunity for neurodevelopment, and that puberty suppression could therefore alter neurodevelopment in complex ways that are not always beneficial and may not compensate later if the window of opportunity is then closed. The long-term effects of puberty suppression during the normative phase of pubertal development on brain development are not known. Therefore, the most important message of my presentation is that more research is urgently needed. We need more information of virtually every kind of aspect of mental health and transgender identity during adolescent development, and particularly to this question of the safety of puberty suppression from the point of view of neurocognitive development and mental health. More information is needed from bigger and more long-term and maybe more comparable studies.
Thank you so much, Rita. Excellent presentation, very informative. And I appreciate your call for more research, and I hope that many people who are listening to would think about participating in the important research that we need to conduct to further understand and to better treat our trans youth. With no further ado, I want to move on to our final speaker. Remind people to use the Q&A to pose your questions. Professor Gary Butler is a consultant and pediatric and adolescent endocrinologist at University College Hospital in London, and holds a personal chair in clinical pediatrics at the UCL Great Ormond Street Institute of Child Health. His special interest is disorders of growth and puberty and Klinefelter syndrome. He's also the clinical lead for the UK Adolescent Gender Identity Development Service, taking an international role lead in the standards of care for transgender children and adolescents. In 2020, he was given the European Society for Pediatric Endocrinology Outstanding Clinician Award. We are very honored to have him here today. Please welcome Professor Gary Butler.
Thank you very much indeed. Thank you for the introduction and for the invitation to join in this webinar today. And it's wonderful, there are so many people from different parts of the world. So I'm a pediatric and adolescent endocrinologist, and therefore provide the physical support to young transgender children and adolescents who are looking at issues related to their gender and wanting any physical support. Next slide, please. So it's important to work out, well, if we are going to provide help for young people, what should that nature of that help be? Next slide, please. Well, in England, we have a national service supported by the a national health service from the government. It's the Gender Identity Development Service, but this is a multidisciplinary team, very much similar to that in the Netherlands and in other countries which have a national service. And this is made up of mental health professionals, social work, therapists of all sorts, psychologists, and also down at the bottom, the specialist nurses and the endocrinologists who come in towards the end to provide the support once young people have been assessed in the first place. Next slide, please. So what is the role of the doctor and what is the role of the physical health professional here? Well, next slide, please. One of the differences between gender incongruence and the disorders or differences of sex development, also known as intersex, is the focus and the diagnostic approach using the chromosomes and genetic base, which is the key in the DSD. We looked at the trans young people to see whether there were any chromosome variations, and our general conclusion in examining 450 was there was no difference from the population. So there appears to be an overt chromosome or genetic reason associated with the gender incongruence. So we no longer assess karyotypes or chromosome patterns. Next slide, please. What about hormones? What hormone checks are needed when we meet a young person? So for trans girls, generally the hormone values are very similar to what you might find according to the stage of puberty. Sometimes you can find the use of exogenous treatment, which can be picked up on clinical examination or hormone investigations, but we don't tend to find any abnormalities in the main. Next slide, please. For trans boys, it's a similar argument. There is a suggestion that there could be excess testosterone or other conditions which cause an increase in androgen-like hormones, but we don't find that at all. And even those who have polycystic ovarian syndrome, which is quite common, as we know, in overweight adolescent females, this is also more prevalent in the trans boys who tend to be overweight, but this doesn't appear to be high enough testosterone to affect physical functioning or behavior. Next slide, please. So our overall conclusion, having looked into the physical causes, that gender dysphoria doesn't seem to be linked with major hormonal or physical problems. And that was our general conclusion that we published in a couple of years ago. Next slide, please. So when we're seeing a young person with gender incongruence, if we need to have a physical approach, it's really the same as we would with any other teenager. And we don't need to take any separate or particular things into consideration. So next slide, please. So what is our assessment schedule when we see a young person for physical intervention? Well, we do normal things like blood counts, iron levels, bone profiles, vitamin D levels. Young people often have unusual eating habits and may well be low in vitamins, including D and iron. We would just take a single blood sample to look at the hormonal status akin to puberty and to make sure there are no problems likely to cause primary infertility. We do a bone density scan, and we also do a general adolescent check-over, physical examination, because there are quite a lot of other things that happen, including self-neglect, self-harm, etc., and people not looking after themselves associated with the dysphoria. Next slide, please. We would only do second-line investigations in more details of hormones, androgens, or bone profile or ultrasounds or karyotypes if we suspect anything wrong from the first panel of investigations. Next slide, please. So what about hormonal interventions? What things are available? Next slide, please. And there are 3 levels, or at least 3 stages. The first intervention is the GnRH analog, which is able to use halt puberty once that has started. We know that is a reversible treatment. The stage 2 treatment is giving gender affirming or cross-sex hormones, and that includes testosterone for those who are registered female at birth and estrogen for those registered male at birth. But those effects are mostly not reversible and more so with time. Now, surgery, which is stage 3 treatment, is clearly irreversible, not only from the fertility perspective, but also from the physical side as well. Next slide, please. So what proportion of children actually seek medical treatment? This is the outcome we published from our studies. This is the number of children in the blue bars referred at by the age of their referral to the Gender Identity Development Service. And the orange line is the proportion who get referred onto the endocrine clinics. And we can see under the age of 11 or so, relatively few young people who are presenting with gender incongruence actually move forward to endocrine intervention. But when we get from the age of 12, it's ranging around about 30 or 40% or even more in the mid-teenage years who request endocrine intervention for their dysphoria. Next slide, please. So what are the options available? Well, this is what I present here is very similar to what Annelou de Vries just presented to you. So that according to the Endocrine Society guidelines, once puberty has started, there is the option of blocking that with GnRH analogues, cross-sex hormones from the age of 16, if that is a next stage after assessment. But surgery is only available, certainly in the UK, after the age of 18 and done through the adults' gender identity clinics, not ourselves. But of course, starting this treatment depends on the competence or the capacity of consent for the young person, and also the legal status if we're involving the parents who to allow the young person to enter into the treatment pathway. Next slide. Now, many of you around the world have been following what's been happening in England at the present time, when the High Court in December last year said that no child under 16 has the competence to decide on treatment. We call that Gillick competence in the UK. And even those who are over 16 who technically have and legally have capacity need to go back to the court to get permission to start this treatment. There was a slight revision in the English Family Court in April of this year, where parents were given the permission to consent to their children to treatment on their behalf. But there's currently an appeal going on in the High Court just now. And in fact, I'm in the lunch break from this appeal, where we are appealing against the original judgment because that infringes the rights of children and young people to self-determine. So I dare say you will hear the outcome of that in due course. Next slide, please. So what do the GnRH analogues do? Well, they prevent the signals to start puberty from the hypothalamus in the brain to the pituitary gland, which makes the stimulating hormones LH and FSH, which stimulate the ovaries and the testes to produce sex hormones. That blocks those directly, and it's a reversible treatment widely used in medical practice. Next slide. Are there side effects? Well, most of the time it's in relation to reducing the sex hormones, and it's akin to the menopause in cis females. If you're taking down sex hormones, you're likely to get some effects, and we do see some of these temporary effects, hot flushes, mood variations, sweats, but most of those settle, and it's mostly in the developed adolescents, those who've already gone further into puberty, who have higher sex hormone levels. Next slide, please. But there are some important things we need to think about when we're starting the treatments, in particular the timing of the treatment. The trans boys, well, if you are reducing or preventing breast development and feminine fat pattern distribution, that may well help identifying. But for the trans girls, those who are registered male at birth, yes, there are huge advantages from blocking testosterone effects on the body, particularly physical changes and the voice. But if you prevent genital growth, including penile growth, that can make vaginoplasty difficult later on, because other processes that surgeons use to create a neo-vagina using the ileum and the gut are not so successful. So we are quite careful about choosing the right time to start treatment in the trans girls with GnRH analog. Next slide, please. So there's also a big debate around as to whether the GnRH are safe to use, in particular for mental health functioning. We wrote an editorial the year before last on this, but there's quite a lot around in the literature and the debate, and the answers are not clear at the present time. It's of course sorting out what is best for each individual young person. Next slide, please. Of course, not everybody identifies in a binary way. So what can we do from the physical side to help young people who are non-binary in their identification? Well, if they are birth registered female, we can use treatments such as contraceptive pill or progestogens to help with stopping menstruation. Some young people just would prefer, when they're over 18, just to have masculinizing chest surgery. And for those who are registered male at birth, we can use things to help reduce hair growth, creams and laser treatment, and GnRH analogs and anti-androgens can be used to reduce the male genital functions if that's causing the distress. Next slide, please. One of the big worries that people have about physical treatment and intervention is about bone health. Next slide. We've looked at this quite carefully, and although when you have young trans adolescents, that's really in the ages of 12 to 15, we do see a fall in the Z scores, in the bone density in both the hip and the spine. But actually, when we actually look at the total bone mineral content here in the trans boys and trans girls, it remains the same. And the apparent density, that's the gold standard measures that we use, that on GnRH analog treatment, there is no deterioration. There isn't the acquisition of bone that we see. And the question, obviously, next slide, please, is whether that will recover when you start sex hormone treatment. And a very good publication from the Dutch group in Amsterdam and Leiden have looked at this recently and showing that when you do start sex hormone treatment, the bone, again, the bone mineral density here in the lumbar spine and in the femoral neck in the hip actually begin to increase back up to appropriate age-related levels. So we do see recovery once sex hormone treatment is started. Next slide, please. Fertility loss is an important consideration here. So next slide, please. And we deal with fertility counseling with every young person we see. Now, although there's the dysphoria, it's still an opportunity to have an age-related discussion about treatment. And of course, young people are not necessarily interested in this, the parents are, but we do need to take this and we need to discuss it with every young person. We take a very matter-of-fact approach, trying to use gender-specific terms. We talk about sex organs, reproductive cells, conception, etc. The problem is that accessing fertility preservation is very dependent on legislation and what's available in your locality or in your country. Next slide, please. Next slide, please. Things that we can do is, we are able to do at the present time in England, we can provide semen collection and storage if the young person wishes that. We can have oocyte or egg retrieval over 16, but we're still getting around the issues of the cost of the treatment here and the process. But also, in the age, there is this prejudice that from a number of areas that this is voluntary infertility, and therefore the public funds shouldn't be used to support fertility preservation. But other procedures are also available now, particularly for the trans girls, such as electroejaculation, surgical testicular removal, or from the testes itself, taking the sperm out. Currently, biopsy of the ovary and the young testes are still experimental treatments. New paragraph. sorry, next slide, please. Conclusions, next slide. So really the take-home messages here are that every gender variant young person needs to be reviewed by a team, not just doctors, but a whole team of people looking after them. When we do need to think about intervention, the evaluation is just the same as we really do for any other young person, nothing specific for a trans young person. We do need to think about fertility counseling and possibly offer reproductive cell storage. Now, some young adolescents may benefit from the pausing of puberty. Currently, we can't find evidence of physical harm in these young people. The timing of this treatment is important in trans girls to make sure we don't prejudice future genital affirming surgery. And of course, we need to have a multi-professional team review again before gender affirming hormones. Next slide, please. Thank you very much. There is the website for the UK Gender Identity Service available, which if you want to look at various resources, and of course the Endocrine Society and WPATH have important resources as well. So thank you very much indeed.
Thank you so much, Gary. Excellent presentation. And now we're going to go to our question and answer. We have a number of questions from the participants, and I'm going to start with you, Annelou. There's a question about when you're dealing with a youth that is with severe gender incongruence and probably might benefit from puberty blocking hormones, and there is an intense resistance from the family. How do you work with them and deal with that kind of situation?
Yeah, it's a very relevant question, of course. Well, first of all, I always say we see a selective sample. First of all, children need their parents to come to our clinic. It's rare and seldomly that on their own initiative they come. If it occurs, and it's maybe a teacher or even child protective services. So that's already a complex case then, and a case where a lot of battle is going on. What we do see though is that I think children come and parents do not agree with each other. One parent is supportive and the other parent is more concerning. But we always involve the parent, and actually, like Rita explained to us, the well-being of the transgender child is dependent very much on how support they get from their parents. But also, parents can be very useful and give good information. Most parents know their children really well, so it's important to hear them, to listen to them, and collaborate as a family. And I must say that usually then we come to a good conclusion together, and we make very good steps that help the whole family forward.
You might answer this, Annelou or Rita, but there's a question about the NICE study, and maybe you can explain that and how that is being used to argue against puberty blocking hormones in youth. Rita, you need to unmute yourself.
Sorry, I didn't notice that. I just can't immediately recall which study it was, so I was hoping that Annelou might immediately know which one you referred to.
It's the NICE report, and I'm not familiar with it either. So maybe you could address again what kind of evidence is being used as evidence that this is not a very good treatment approach.
Well, I'm wondering, is the NICE study, Gary, that's not the early intervention study, isn't it?
No, just to briefly explain, the UK government has a health watchdog which asks to look at evidence around the treatment. The problem is they only look at and able to look at things like randomized controlled trials or systematic reviews, and they discount any observational studies. So therefore they concluded there were no RCTs done, so therefore they couldn't make any conclusions, and that was simply the fact.
And in addition to that, I think Rita also explained very well how all research that's out there has research limitations. But we also should realize that the ideal design of, yes, a double-blind controlled trial is just not a possible design. You could never provide a blind puberty suppression or a blind affirming hormone treatment. And it's also unethical because we all know that a lot of the children, a lot of the adolescents suffer enormously under their puberty. And we have seen the helpfulness of it. So by now, not providing puberty suppression is not a neutral act anymore. But on the other hand, we should acknowledge that, yes, there's a lot we don't know. There are a lot of uncertainties, and that's the reason that I think we should do this very carefully with the involvement of people who know where they're talking about.
Well, yes, I also want to add in this that the people who participated, the first Dutch studies and the only long-term follow-up, they were carefully selected, and it was really, really carefully done. And now as the practices are spreading into the world, then the quality of assessment and the carefulness that was followed in the Dutch study may not always be on the same level. And even though definitely it's very unlikely that this could be subject to randomized control studies, which is normally the main route for any medical intervention to be accepted in the medical practices in general in healthcare, then at least we should carry out much larger term studies. There will be more individuals and longer follow-up studies, and I think that because nevertheless it takes a lot of time and all the clinics meet a small number of people, then it should be actually preferably multi-center studies and across different countries that could together maybe provide more relevant information, and also using more similar assessments, because nowadays everybody's using their own instruments. So there is a wide variety of instruments that are not comparable when using the results. Only what is really known that people are usually satisfied with the changes that are accepted, particularly after the gender affirming hormones. But otherwise, the results are not so high quality.
There's a question about, there are cases where people are, youth are evaluated in a couple sessions by a practitioner and put on puberty blocking hormones. So what is the standard to really be able to carefully evaluate and make this decision, especially in light of the evidence as it stands and the concerns about cognitive development and bone health, etc.?
Well, I think that in these countries that are now represented in the panel, we all use multi-professional teams that carry out the careful assessment, including many meetings with the adolescent and with the parents and together and separate. And there are psychologists and medical doctors and social workers and nurses in different combinations, all collecting information and talking with the people. So it's an evaluation, it's a process of finding the solution with the adolescent, not just a series of measurements. So it's a process of discussing, and multi-professional teams are involved in this discussion. So I don't think that in any of the panelists' countries, just a couple of meetings with one single professional would be sufficient.
Thank you. I think just to add to that, thank you, Rita. It's important that once the young person is assessed, and then if they are going to be referred to an endocrine team for treatments, then a further assessment by the doctors concerned takes place. And that is what is being challenged in the English High Court at the present time, as to whether the young person has the competence or the capacity to make that decision. And that's an important step as well. This is something the young person wants. And so there's that extra step that is needed to take place before a young person can be assessed as to whether they're ready for treatment.
Mm-hmm. I don't know how much evidence that we have of youth that have very early puberty and may go on puberty blocking hormones earlier for longer periods of time versus shorter periods of time. And do we have any evidence of the length of time that they are on and the effects on positive or concerning effects at all?
Well, I think we should be honest, and we don't have that. And I know the design that we presented, the three of us, that's true. It's quite similar. So we in Europe tend to have a quite long period of puberty suppression in the young ones before we go on with affirming hormones. And preferably not before the age of around 15. But it's true, practices are different in other parts of the world. And sometimes it's also due to costs, due to availability of GnRH analogs, or due to concerns about the consequences for example, bone health that Gary was reporting on. Are starting at an earlier age, and that's one of the things we just don't have the data how that will work for the young ones, and we should balance all the time, despite the fact that there's a lot we don't know yet. There are barriers to care. And the involvement or the careful assessment or the careful guidance that we give is experienced by many as an enormous barrier to care. So I think we are in a position where we on a day-to-day basis have to balance what we know with what we don't know, and then make decisions.
Mm-hmm. So maybe this is a question for Gary. When a person has been on puberty suppression for a long time and they want to detransition, quote unquote, what would be the therapy course that would be helpful to them in going back?
I think we do see this, and actually, a lot of young people who are being on treatment with GnRH analogs and have the ongoing assessment may well reconsider their journey. But actually, because of the reversibility of GnRH analogs, everything just picks up from where they started. It is a truly an endocrine pause button. So they will resume puberty and resume the physical changes linked to their birth sex. So there really isn't a problem there, and that's been well studied at the present time.
Mm-hmm. Also, Gary, people are very curious about, while there's a pause on puberty blockers, what does care treatment look like at your center? And yeah, what's happening?
I did quite follow in terms of the ongoing care. Well, the young people are seen regularly by their psychosocial team for assessments all the time. Things are reconsidered, and we would just monitor the efficacy of treatment of the young people on their sort of endocrinology and bone health and physical growth.
But again, isn't there a pause in terms of starting people on puberty blocking hormone?
I see at the present time, it is where it's complicated in England, that currently there is an agreement that young people, their parents can consent them to start treatment, but there's just then it's making sure an extra review process takes place. So it is possible for young people to start. What is being debated today is whether it's the young person themselves can consent to treatment, or is it still reliant on the parents?
And maybe you can comment on what's going on in Sweden and the policies there, and how both the situation in the UK and in Sweden may affect things around the world.
I know in Sweden there's been a pause based on the looking at some of the publications from this UK NICE report, the National Institute of Health and Care Excellence, which, as we have discussed, does not take into account evidential information. It's just looking for RCTs, which Annelou has described as actually impractical and unethical. But I think I know around the world, and there's many participants around the world at the present time who will have different situations in each of their countries. And you know, within the UK, it's different. I mean, we have 4 countries in the UK, and each one has a different approach, which doesn't help.
Mm-hmm. There are some questions related to mental health, and Rita, you might be able to answer some of these. Is there any increasing mental health disorders that you see when using puberty suppression hormone therapy? And also there's a question about is there any similarity or differences with adolescents with eating disorders with gender incongruence and the level of mental health concerns that they might be dealing with?
Well, firstly, if you think about the studies that have reported on the psychosocial development or psychological development after starting gender affirming interventions, then they have not reported that there would be decline on puberty suppression, but some have reported that there have been some improvements in emotional symptoms, but mainly within clinical range, or then they have not been reporting during the puberty suppression statistically significant changes, and more changes are reported during the phase of gender affirming hormones. But then again, not always the symptom decline has many times been within non-clinical range. So it's not the same if you have mental health symptoms measured by some kind of a self-report scale, or you have psychiatric diagnosis that requires specialist level treatment or can be diagnosed, and then they are different issues actually. And mainly the studies have not focused actually on diagnosable psychiatric disorders, but psychological symptoms as reported by self-report measures. In our Finnish study, we noticed, we retrospectively evaluated what had happened with the young people who had gone to gender affirming hormones and were followed up by the mental health team for at least for the first year. And during this year, we noticed that there had been some reductions in treatment needs for depression and anxiety, but there were also new emerging needs for psychiatric treatment, so new diagnosable disorders that had not been there before. So findings were mixed. Then as to the eating pathology, which was, by the way, in our material very rare and has not been discussed much in these studies on adolescents conducting gender identity services. It's only in the population studies there have been some references to eating disorder issues, and then there are some case reports, but case reports are of course always kind of teasers because it's not really a research study. I mean, it cannot advise for groups if you have a present case report. So some writings have nevertheless been published that consider the possible association between eating disorders or similarities and differences maybe between eating disorders. Then eating disorders are usually considered mental health problems or psychiatric disorders in themselves. And eating disorders have lots of comorbidities, and those comorbidities are indeed exactly the same. Depression and anxiety are typical comorbidities of eating disorders, and they are typical comorbidities of gender dysphoria. But more understanding of possible similarities and differences and relationship between these conditions it would be interesting to get this information. It's not there yet.
Mm-hmm. Rita, or well, any of the presenters, we know about the association with autism, and when do we see any kind of improvement of symptoms after puberty suppression or masculinization or feminization hormones? Again, there's been a debate about whether some of those symptoms are related to the gender incongruence or is really autism. So do we see any improvement, or does it remain the same?
I am not aware of research studies that would have really studied this carefully with rigorous research methodology on group level. I have only seen one poster presentation in a conference where they concluded that the basic phenomena or the basic autism problems did not change. But of course, people on autism spectrum nevertheless can improve as to their gender dysphoria. And generally, if you think about an adolescent who has autism problems and usually has a lot of problems here and there, because autism can be a very severe condition, then of course, if you get better in one domain of your life, it can make the other domains more manageable, or you're relieved and you can function better if you get rid of some anxiety. So it's possible that generally adolescents who are successfully treated as to their gender dysphoria and benefit from this treatment, this might allow them to use their mental capacities and their strength to other issues, but the core phenomena of autism are, to my best knowledge, they don't change, because it's a developmental condition, and it is basically, there is no cure for that actually.
Mm-hmm. Okay, thank you. There's a question about the effect of puberty blocking hormones on what happens to the adolescents dealing with their sexual attraction, that they're maybe out of sync with their peers who are going through puberty and raging sex hormones, and how are they developing in terms of their sexual attractions and sexual development and orientation during that time? Maybe Annelou or
yeah, well, I can say something about it. We did study it, so that's always nice if you have research findings. And when at baseline we asked about sexual experiences and compared that to same age peers. So in the Netherlands we have like a bi-yearly, I think, big evaluation study about sexual experiences, romantic relationships, sexual milestones, and we compared. So we could compare our transgender referrals to the Dutch population, and well, I think not unexpectedly, their milestones were later compared to their peers. Generally spoken, although a lot of them still had romantic relationships and had sexual experiences. And then we also did follow-up. So after affirming treatment and surgeries, and yeah, it as expected, there was some sort of they were having experiences more after treatment than before for a subgroup. From the clinical perspective, what I see working with the transgender youth, well, a lot of them say, I wait a little, maybe after my treatment, and then once it's there, it's quite difficult, and they feel hesitance, and I really well, I really want them to find support in that, or find help, or find a good sexologist, or go to therapy. But for a lot of them, it's difficult to ask this sort of help. And then I think they often, I think that's good from social media. I saw Gary was asking was answering a question. There they find their peers. So I think they can learn a lot from their transgender companions. And that's the good thing. I think they find each other on Facebook, and they learn a lot from those groups. And I think being in such a group with other LGBT youth is very helpful in this as well.
I think that's right. I just add to that. I completely agree, Annelou, but we give contraceptive advice to all the young people we see, which is really important because many of them are sexually active and in different ways, not necessarily in a trans heterosexual relationship. So we give open, straightforward, non-discriminatory advice to all young people about contraception. And then I think it's really important. And also prevention from sexually transmitted diseases, as well as unwanted pregnancies, if that type of relationship may occur, because you can't rely on sex hormones or puberty blockers to provide the contraception. So that's blanket advice to all our young people.
Thank you, Gary. Unfortunately, we've just got a few more minutes here, and this is we could probably go on for several more hours because there's a lot of questions. There's a thirst for knowledge, and I would think that all of the panelists would concur with me that in order to do this work, training is really essential, and working in these multidisciplinary teams. It's disconcerting that people are thinking that they know what they're doing, and this is something that needs to be carefully considered. And so again, I encourage people to become a part of ISSM and WPATH, and really stay up with the literature, think about training programs, continuing education, because the field is emerging rapidly, and to stay abreast of those developments is really very important. So I'm going to turn it back to Annamaria and Walter Bouman. And I just want to thank our wonderful presenters for being with us today and providing us with such valuable information. So Annamaria and Walter, it's over to you.
So much, and I want to echo your thanks to three excellent speakers, world-known experts. I mean, thank you so much for taking the time and sharing your great knowledge with us. And thank you, Eli, for moderating this session. As you say, we have many more questions. And I also want to thank the audience for all the questions and the comments and remarks that we have both in the chats and then the Q&A. And finally, I want to thank WPATH, you, Walter, for co-arranging this with us. I think it has really been a pleasure, and I think we can do more about this in the future to collaborate. Finally, I just want to advertise a little bit our next webinar. ISSM has a webinar the last Thursday every month, and next time it will be something completely different. It will be on post-SSRI sexual dysfunction, and in August it will be about communication about sexual problems in the clinical setting. You can all register now. It's open for registration, and also please remember that this webinar will be available on our webpage in a few days. You will see this webinar. You can go in and watch it there too. And finally, thank you very much for participating, and I'll give it over to you, Walter.
Thank you, Annamaria, and yes, thank you all the excellent speakers and moderator, and particularly ISSM for hosting this. And then I just would like to mention Lillian and Miro from the ISSM Secretariat, who've been absolutely phenomenal. And then very quickly before we close, just really want to share with you the Epath Conference, which will be a hybrid conference in Gothenburg, Sweden, from the 11th till the 13th of August. There are still places, and there are, of course, unlimited virtual places available. See at www.epath.eu. And then also in November, we have the Scientific Conference of USPath, which is also a chapter of WPATH, which will only be virtual. So thank you very, very much, everybody, and stay safe and take care. Bye-bye.